right, Health and Human Services Finance Committee will come to order. We do have a quorum. Representative Heinzman moves approval of the minutes from March 21st, 2017. All those in favor of approval of the minutes from March 21st, please say aye.
Aye.
All right.
Those opposed, no. Minutes are approved. First up, we have Representative Albright. Representative Albright moves House File 1386, be held over for possible inclusion in the Health and Human Services Omnibus Bill. There's no amendments. There are no amendments. Fiscal note. Representative Albright.
Thank you, Mr. Chair and members. 2 points to remember when you consider 1386, and I'll make them brief. First, the bill doesn't increase rates for anyone. It simply slows the decline for those who are getting the worst, and the price tag simply reflects that way too many people with disabilities are getting harmed way too much under the disability waiver rate system. I have Tom Weaver with me today, and he will take care of the rest of this dissertation. Thank you.
Welcome to the committee, sir. Please introduce yourself for the record and proceed.
Mr. Chairman, I'm Tom Weaver. I am the CEO of Achieve Services. We are a day training and rehabilitation provider located in Blaine, serving about 190 adults with developmental disabilities, primarily in Anoka County, but also in surrounding areas. This bill simply is intended to provide a softer landing for many people with developmental disabilities who are seeing significant rate cuts under the new rate system. At Achieve, for example, on average, our people will be experiencing a 34% cut in their rates effective on January 1st of 2019. What this bill does is for those seeing more than a 5% decrease in their rates, it would phase those rate decreases in. So rather than seeing, if you're losing 35%, you've already lost 4 to 5% through a 5-year banding period. Then in 2019, you'd hit a cliff. You'd lose 30%. Under this bill, you'd continue to decline by 1% a year until you get to that new rate. So these folks are going to see a rate decline, but this provides a softer landing, so it happens over a longer period of years, ensuring that they continue to have access to services.
All right. Is there anybody in the audience who'd like to testify on House File 1386? All right, seeing none, we will close that off and open it up to member questions. We have questions. Representative Liebling.
Thank you, Mr. Chair, and thank you for being here, Mr. Weaver. We certainly on this committee have a great interest in making sure that people with disabilities get the services that they need to live as independently as possible. That is all of our number one concern. We also know that we have a limited, and we'll always have a limited budget to do that. That's just the nature of the beast, if you will. I would like to know, as we talk about what is potentially going to happen in your business if we don't extend this banding, I'd like to know what is it that you report when you tell us that this is going to have a severe impact on your business, and I have no doubt that you are telling us the truth. What information do you share with DHS that would allow DHS to make decisions about these kinds of issues, or that would allow us to make decisions? In other words, what I'm talking about here is going back to the report that we recently received from the Office of the Legislative Auditor, which you may be familiar with, because this is pretty important in your area of work. And what the Legislative Auditor is telling us is that we in state government don't have enough tools to really completely understand where our money is going in the area of home and community-based services. So I'm just wondering from your end, what do you report to DHS that would help DHS understand the whole landscape of what DT&Hs are doing and where the money is going?
Mr. Chair, Representative Liebling, we do report. Obviously, we give them everything they ask for. They know what rates we're paying to our people. They know the services that we provide to our people. Beyond that, I'm not sure what information that may be a question they could respond to a little more accurately than I can.
Representative Liebling.
Thank you, Mr. Chair. Well, I'm sure they have their response, but I'm just kind of wondering from your point of view as a service provider, do you provide detail to them on how many people you're employing and what you're paying them, and exactly which services each of those people is involved in providing?
Mr. Chair, Representative Liebling, the department they put out surveys and questionnaires to providers on a fairly routine basis, and we provide all that information as it's requested, yes.
Okay, so, Mr. Chair, so, Mr. Weaver, so you're saying that it's kind of on just sort of a one-off basis, not that you have a regular report that you make on a consistent basis? It's just kind of, if they ask, you tell them, but if they don't ask, there's no kind of annual or quarterly report or anything like that?
I'm not aware of a regular report that we provide to the department, but again, we do on a pretty regular basis provide the information that they request from us.
Okay, thank you very much.
All right, other questions? Seeing none, final thoughts, Representative Albright.
Thank you, members.
All right, with that, House File 1386 is held over for possible inclusion in our Health and Human Services Omnibus Bill. Thank you, Representative Albright. Mr. Weaver. Next up, we'll do House File 10. Mr. Chair and members, I will move House File 10 be laid over for possible inclusion in the Health and Human Services Omnibus Bill. I also have an A2 in the packet. I'd like to move that now for the A2.
Representative Dean moves the A2 amendment. Discussion to the A2 amendment, members.
What this members does, it anticipates future waivers that may or may not be requested for moving ahead. And what this says is if a waiver is sought, that the administration can't do that without the legislature. So if we're gone this summer and this fall and the administration is working together with the folks in Washington, D.C., that this would say that they have to come back and check with the legislature first before moving forward. So it's pretty self-explanatory.
Members, all those in favor of approving the A2, I'm sorry.
Yeah.
Representative Murphy, E.
Thanks, Mr. Chair, and thanks, Representative Dean, for explaining what the amendment does. So in simple terms, this would just say that if the administration is pursuing a waiver, even at the direction of the legislature, that without the approval of the legislature, after working with the Trump administration, that the waiver would not be allowed unless we were in session and we approved it.
That's correct.
All right. And Mr. Chair. And
Representative Murphy.
Representative Dean, Mr. Chair, can you just shed a little light on why this is important? Why we should consider this, please?
Chair Dean.
I get nervous that they're going to do stuff when we're not here that we won't like.
Representative Murphy.
And thank you, Chair Albright and Chair Dean. When I think about the reinsurance bill that is now in conference committee that requires a waiver, if we were to successfully pass that piece of legislation, the governor signed it into law, but the federal government, the Trump administration, weren't able to act on that in the time between now and the end of May, then effectively, if we pass this, that would be then on hold. That $300 or $600 million to the insurance companies would be on hold until we came back next February to approve it. Is that the way this would work?
Chair Dean.
This would state that any 1332 waiver under the Affordable Care Act, I'm not exactly sure if that is a subsection of that, or I'd have to check on that to see exactly what the size and shape and number that we are currently asking for in the latest bill.
All right, and Mr. Chair.
Representative
Chair
Murphy.
Dean, I appreciate that you don't want the Dayton administration to do anything that you wouldn't like with the Trump administration, and, I might share that view with you just in general, but I think this is an unnecessary hand-tying of the administration in a way that could really slow down efforts, if there were efforts to try and bring reform or opportunities for that to the people of Minnesota. And I, appreciate our authority and the authority of the executive branch, and those check and balance one another, but I think this goes too far.
Chair Dean.
Be happy to sand it off and sharpen it in any way that we can between now and the end, and would look forward to your help.
Representative Halverson.
Thank you, Mr. Chair, and I'd be curious if somebody from the Department of DHS or Commerce could comment on what the practical effect is. I know that we've been getting more and more pressure from the Trump administration with regard to reinsurance, and it being having a Minnesota reinsurance plan being viable without a 1332 waiver is becoming more and more apparent to us, I think, what we've heard from the administration. So, thank you. Here's Mr. Brickwitty.
Welcome to the committee, Mr. Brickwitty. If you could just state your name for the record.
Mr. Chairman, for the record, Peter Brickwitty from the Department of Commerce. Representative Halverson, I think the way that we're reading the A2 amendment, which we just saw for the first time a couple of hours ago, I think paragraph C would likely inhibit the state's ability to obtain any sort of 1332 waiver. I can't comment on any other federal waivers, but specifically with regard to 1332 waivers. 1332 waiver applications require an express legal authority in order to even submit an application. So if the Commerce Department were going to seek a 1332 waiver, we need express authority and direction from the legislature to do so. I think it would, I have not checked with federal regulators, but I think it is likely that that a second legislative approval step subsequent to federal approval will likely cause the feds to not give us approval in the first place. So I think paragraph C may be an impediment to seeking state innovation waivers. Happy to work with the author, but I think understanding the intent of implementing it, but we're not even able to submit an application without express direction from the legislature to do so.
Representative Halverson.
Thank you, Mr. Chair. And since we are up against such a tight time frame with regard to reinsurance, can you comment at all on what direction we're getting from Commissioner Price or Secretary Price with regard to their expectations for our waivers?
Mr. Brickwitty.
Mr. Chair, Representative Halverson, Secretary Price did send a letter, I believe 2 Mondays ago, to all 50 governors encouraging states to pursue 1332 waivers, specifically highlighting an application that is currently being evaluated by the federal government from the state of Alaska pertaining to that state-based reinsurance program.
Follow-up, Representative Halverson.
Well, Mr. Chair, I think that we should think long and hard about adopting this amendment. It doesn't sound like it's ready for prime time. If it could at all push us into a situation where we're not able to continue the important work we're trying to do on reinsurance, so making sure that we are getting some relief to folks in the individual market, then we're kind of fighting against ourselves at this point. So I would encourage the author to work on the amendment more before it gets adopted.
Welcome to the committee, Mr. Rocco. If you could just state your name for the record and respond to the conversation.
Thank you, Mr. Chair. Nathan Morocco, Assistant Commissioner with the Department of Human Services. We would just add, and again, we've only had this for an hour or two, but while Section A is specific to 1332, and I think Commissioner Brickwitty sort of had presented any potential concerns there. Section B is fairly broad and it isn't specific to 1332. So I'm not sure the intent of the author, but we could certainly see a situation where we're talking about other kinds of waivers, 1115, 1915Bs and Cs, or state plan amendments, areas where we have already been given authority and are working off of waivers, but we certainly are having a lot of exchanges with the federal government where we are renewing waivers, and the language is relatively broad. So again, not sure the intent of the author, but the initial read is that it would be broader than 1332 and would also get into areas where we already have existing authority, but are just working with the federal government on renewals.
Comments, Chair Dean?
Well, I think if you look at line 1.10, before submitting an application for federal waiver approval, that the submission for approval, I would, the intent, and I think any plain reading of that would be that it would not be for approvals that have already been in effect. But I'd be happy to work with the department in making sure that we don't slow down the, if the reinsurance bill moves forward, that or anything else that we want to have move forward. And just, like to point out that I have in the past challenged Governor Dayton's executive authority within the legislative bounds, but I did also sue Governor Plenty for the same thing, so.
Representative Liebling.
Thank you, Mr. Chair. I was going to focus on that same paragraph C. And as I'm reading that, it looks like it would prohibit implementation of authority that was already applied for or already authorized, that already has been authorized. So if a state agency is prohibited from implementing or acting on a federal waiver or approval that is received or granted, that is very broad, and that includes stuff that's already been applied for, as I'm reading that. So I think this is very, very concerning language, and I guess I'd like to hear what you have to say about that, Representative Dean, because maybe you didn't intend it to go quite that far, but I think that's what the language does.
Chair Dean.
Mr. Chair, Representative Liebling, that's certainly not the legislative intent. That's not how I would read it. You're an attorney, I'm not, but I would read it as the administration seeking additional approvals from the Trump administration. And I would think normally, Representative Liebling, you'd like that, but maybe not in this instance. So, but that's the legislative intent. That if there are approvals, I think this committee and the policy committee should, and the Commerce Committee, really do need to look at and approve any plan redesign that we have, because this will really affect how people get health care in Minnesota if there is a broad change. And I don't think the chances of that happening are very great, but I have seen this before, and I want to make sure that we protect, as a legislature, our rights and our responsibility to approve the way that Minnesotans are getting taken care of.
Follow-up, Representative Liebling.
Well, thank you, Mr. Chair, and I think I don't really see how you can read this any other way. It doesn't say anything about when the federal waiver or approval, when this, maybe the enactment clause or something would make a difference here, but it sure reads to me like this requires us to come back and pass a law even for stuff that's already been done. And I guess I have a little bit different orientation toward this than you do, Representative Dean. We are a part-time legislature. Some people here actually have other jobs, and I don't think we should be micromanaging our agencies. I think it's good that we should know what's going on, and reporting to us and letting us know, I think is great. But in between times when the legislature's not in session, to say that things can't go into effect unless they're approved by law, I think that's a pretty heavy burden, especially given what we already heard, that there has to be approval for the waivers even to be proposed to the federal government. So I think this is really, needs to be tightened up at the very least.
Representative Pinto.
Hey, Mr. Chair, I share the broad concerns about the bill, but I just want to clarify a narrow point that was made by a testifier before. As I read subsection A, this definitely does, just to confirm, we're not just talking about waivers or approvals under section 1332. I think the testifier earlier kind of said that there seemed to be some ambiguity about that, but to confirm, the waivers or approvals we're talking about are any of those that would affect the administration of healthcare programs in the state and all the other things listed in there. So this is quite broad, and I would agree with Representative Liebling's interpretation of subsection C that boy, if a commissioner is going to be attempting to implement or otherwise act on any federal waiver or approval, then we have to, after it's received or granted, and this would be in the past as well, are going to have to come in and provide specific approval at that point, even if there's been past approval. Thank you, Mr. Chair.
Chair Dean, any comment?
All right. Yeah, I think there may be a technical oral amendment to 120 if the committee would entertain it. Staff has just suggested it to me to kind of address Representative Liebling's concern and tighten it up a little bit more. Maybe not to her satisfaction, but maybe to make it a little better. And I think we'll probably have that in a couple seconds. But that's obviously the legislative intent is that they couldn't cut a deal with federal government to redesign our programs while we're gone and have that enacted, because I don't think anybody on the committee would want that, and that's kind of what the intent is.
Ms. Clark, please.
Mr. Chair and members, I would suggest on page 1, line 20, before the period, insert "and applies to federal waivers and approvals sought on or after that date."
And could you repeat that just one more time for everyone?
Page 1, line 20, before the period, insert "and applies to federal waivers and approvals sought on or after that date."
Representative Loeffler.
Well, thank you, Mr. Chair, and I think that helps clarify to some degree, but what I heard from the Department of Human Services is that we have a lot of renewals of waivers. I mean, we have 5 of our biggest programs are operated under a federal waiver, and we have to renew them every once in a while, and I'm wondering whether or not the word approval is connected with that renewal process. And so if they have to renew in, say, August, and it's effective October 1st, you know, would there be a suspension of a program potentially until we could come back into session and say, yeah, go forward and continue this good work? I'm just wondering if we need some specific language related to renewals, because many of our programs that we think are permanent and established are really on a continuing review process and extension with the feds, and maybe that's something we need to get some technical help with from the department before this becomes final.
Any other questions while we're working on Ms. Clarkfist? Do you have a modification?
Mr. Chair, if Representative Dean so chooses, we could add, we could modify the clause added slightly to read "and applies to initial requests for federal waivers and approvals sought on or after that date." But that's
Chair
up
Dean.
to the author.
Chair Dean.
I'd move incorporation of the oral amendment if the Democrat lead would suggest that it's technical in nature and minor. Otherwise, we don't have to.
Representative Murphy E.
Mr. Chair, Representative Dean, I think that I think the amendment's technical in nature, and I think that is right for us on both sides of the aisle to have the kind of flexibility necessary to take up amendments that are technical in nature, so I won't object to that. But I do think even the amendment is an illustration of, I think, the nature of the problem with this amendment in general. And so I won't object to moving forward with the amendment. I'm not going to roll call the amendment, but I do think that we are locking down in a way that, seems evident to me, Minnesota's ability to bring any measure of nimbleness, and it's funny to think about the Department of Human Services or the legislature or the government being very nimble, but especially in a period of so much uncertainty right now, by stripping away one more measure of our ability to react to what's happening with either branch of the government on behalf of Minnesotans is unwise.
Representative Liebling.
Thank you, Mr. Chair, and I just have a question to the oral amendment, and it was waivers or approvals sought on or after that date. I'm not sure what that date refers to here.
Ms. Clark, please.
Mr. Chair and Representative Liebling, the date is the day following final enactment, the effective date of the section.
Representative Liebling.
Okay, Mr. Chair, thank you, and I assume from Ms. Clarkvist that that's how that normally would be phrased. It just, maybe if I saw it all printed out the way it would be if we got this initially, maybe it would be clear to me, but, okay. That's okay. If she believes that's clear and says that, then that's fine.
Ms. Clark-Fist, why don't you read the amendment as it's been adjusted before we take it up for consideration one more time?
So, Mr. Chair and members, I'll just read all of line 20. So line 20 will read effective date. This section is effective the day following final enactment and applies to initial requests for federal waivers and approvals sought on or after that date.
So members, all those in favor of amending the A2 amendment as incorporated, we're incorporating the oral amendment into the A2 amendment as, we're voting on the A2 amendment as orally amended by,
Vote on the oral amendment.
we're modifying line 1.2.
Can't wait.
And we have to We have. So the question before the committee is to adopt the A2 amendment as orally amended with the incorporation of the oral changes.
Amen.
So, Mr. Chair, I think it is technical, but it's not just a language change, and I think we should vote on the amendment to the
I
amendment.
agree.
Yeah.
So, members, we are going to take up the motion to approve and adopt the oral amendment to the A2 amendment as heard.
With our ears.
All those in favor say aye. Aye. Opposed?
No.
The oral amendment as is adopted.
To the A2
Now-
amendment as adopted.
So now,
All
Mr.
right.
Chair Dean, we are to the A2 amendment as amended.
Thank you.
Representative Pinto.
Thank you, and I just do want to point out the testimony before that we won't be able to make initial requests if the agency has to go back to the legislature for approval after the fact. The request can't even be made without having legal authority, so we're putting the agency in a box and doing this. So the amendment is good, and it's good that it's going forward, but just to realize that the agency won't even be able to make the request if subsection C is still in there. So I plan to vote against. Thank you.
Chair Dean.
Just renew my motion for A2.
Representative Schultz.
Thank you, Mr. Chair. I don't know why we would want to adopt this amendment and jeopardize millions of dollars of potential federal funding and preventing our agencies to working with the federal government to improve our budget in Minnesota. I don't know why my colleagues across the aisle would want to adopt this amendment and constrain our agencies from doing the right thing and trying to maximize federal funding for our public programs.
Members, all those in favor of adopting the A2 amendment as orally amended, signify by saying aye. Aye. Opposed?
No.
Motion prevails, and the A2 amendment as amended is adopted. Chair Dean, to your House File number 10 as amended.
All right. Thank you, Mr. Chair and members. House File 10 is, for those of you who were here last term, is the same bill that I brought forward last time. And that is moving away from MNsure. As many of you know, who've served on the committee in the past particularly, we've had a great difficulty in trying to operationalize MNsure. And several of the states that have kind of gone down the same road we have in the past at the same time have already turned back and gone the other way, stopped spending good money after bad. And you might ask yourself why they did that. Were they all Republican states that were doing it as an opposition to the Obama administration? Probably not. If you look at Oregon and Hawaii in particular. These are states that just couldn't operationalize the idea because it was an audacious IT project that got foisted upon really good state workers that couldn't react in time and ended up hurting people. They'd say, well, maybe we did that because there was a big tax advantage, because that's what we were told initially. If you set up a state-based exchange, you're going to get a big tax advantage. Well, Wisconsin set up their exchange, or decided not to set up an exchange, and according to the Supreme Court, they said they were entitled to every bit of the tax advantages that we had gotten, even though we had started off on the medical experiment of a state-based exchange. So we didn't have any advantage from actually delivering services to people. The IT was rolled out too fast, too big a project, too big a bite to bite off. And we have not seen any tax advantages to that. So from a tax standpoint, we're a chump state because we paid $400 million for something that doesn't provide any tax benefit to us. It's actually costing us more. And we've shown in this committee and others that it is an inability to help people. Also, I think what the latest projections from MNsure has shown that they have not met the test of self-sufficiency. They've not been able to produce the revenues necessary for self-sufficiency. So from a standpoint of have we met our goal from self-sufficiency? No. Have we met our goal from IT stand up and run? No. And in fact, the GAO's last report for functionality within MNsure showed that in fact none of the areas tested are functional in IT. We've run out of federal money to spend on that in the next year, so we will transfer all of that unless we get off the dock and into the canoe here. We are going to be on the hook for every penny of IT development because those federal funds are now gone. So from that standpoint, I think it's quite clear that if you were maybe on the fence a year ago, the evidence is very clear and growing that we need to move in this direction. We are looking at moving away from MNsure and trying to reconnect people to the health care that they had before. And that's what House File 10 does. The amendment looks at some changes that are going on in Washington, D.C. right now. There's some folks there who are really intent on allowing states great flexibility, which I love, I think we can lead again. We're a high-quality, low-cost state that we deliver health care better than anyone else, and I think we should lead instead of follow. Hopefully, we will be allowed to do that, but I am concerned that the legislature decide that and not bureaucrats in our absence. So that's what the amendment tried to do and will try to do, and we'll try to do with House File 10 moving forward. I understand there are some folks who would like to testify on this, and in the interest of time, we'll take questions from there.
So are there, or is there anyone in the audience that would like to testify to the bill? All right. If you want to just make your way towards the testifiers table, and if there are a number of you, then why don't we just have you all kind of line up, and so we can get your names for the record. So we will be hearing this tonight. No? Yeah, the hope is that we're not coming back tonight, so if you could be brief with your remarks, that would be helpful for everyone else in the audience. So we want to just go one at a time. Please state your name for the record and who you represent.
My name is Andrea Sorm.
Welcome to the Representative Considine.
Thank you, Mr. Chair. I was just wondering, in the interest of making sure everybody gets the opportunity, if we could put a 2 or 3 minute time limit on each person.
I think Representative Considine, they're well aware of the brevity of their remarks, probably makes more impact than long-winded speeches. So with that, welcome to the committee.
Thank you.
You could just restate your name for the record and who you might represent.
My name is Andrea Sorm. I'm representing myself and all people in Minnesota Care. I'm a single mom raising 2 boys and working as an independent musician. I'm originally from Harmony, Minnesota, in the southeast corner of the state, and I now currently live in South Minneapolis. Like most self-employed artists, I piece together my income from multiple sources. I'm a piano teacher, a part-time church music director, and I perform for live events. I do vital work for the musical and spiritual life of South Minneapolis. I'm extremely grateful for Minnesota Care. It was there to catch me and my family when we needed it. At the time, I was divorced 2.5 years ago. I was a stay-at-home mom with a baby and a preschooler. Since then, I've grown my music teaching business and started working at a church part-time. I'm steadily paying more for my Minnesota Care premium, and I'm proud to say that in the next year or 2, I may finally make enough money to not need Minnesota Care anymore. I will be happy to pay for my health insurance premium and would be especially excited to buy into Minnesota Care if that becomes an option, as it is the best policy I've ever had. In the interim, while I am supporting myself and my kids on a low income and no child support, Minnesota Care has been absolutely essential. It is because of Minnesota Care that I am able to share my passion and talents as a musician and teacher and do the work that I am meant to do as a church musician. Without Minnesota Care, independent artists and entrepreneurs like myself who are older, have pre-existing conditions, or children might not be able to continue their careers. Imagine what Minnesota would be like without independent artists, musicians, private music teachers, and small businesses. Minnesota Care is critical not only for low-income Minnesotans like myself, it is critical for providers who bear the burden of cost when those without insurance need emergency care. I love that the word care is in Minnesota Care. It truly is an important way we care for each other and make this state great. The federal exchange is not compatible with Minnesota Care. Shutting down MNsure and switching to the federal exchange will eliminate Minnesota Care and leave people like me who cannot afford to buy private insurance but who do not qualify for medical assistance without any strands to pick up. It effectively would punish someone like me who is trying to escape poverty. Please do not eliminate MNsure and switch to the federal exchange. It would hurt me and so many others who want to grow their business and contribute to our communities. Let's continue making Minnesota a welcoming and vibrant state for all of us. Minnesota Care is one of the best reasons to call our beautiful state home. Thank you for listening.
Next. Thank you for your testimony. Welcome to the committee. If you could please state your name for the record and provide us with your remarks. Thank you.
Thank you. Good afternoon. Representative Albright, members of the committee, my name is Jenny Peterson, and I'm the Executive Director of Generations Healthcare Initiatives. Generations is a private foundation located in Duluth. For the past 15 years, our major focus has been to reduce the number of uninsured in our area. We coordinate the Insure Duluth Coalition, which utilizes MNsure grant funding and considerable local resources to expand health coverage in the greater Duluth area. I'm here today to state our position on the advantages of preserving Minnesota's health exchange and the disadvantages to going to the federal exchange. Since the establishment of MNsure, Minnesota has experienced more than a 50% decrease in the uninsured rate, going from 9% to 4%. And Minnesota now has one of the lowest uninsured rates in the nation. In our northern region, it has been extremely gratifying to see countless people who now have health coverage for the very first time. We view this as a tremendous success in improving the health and well-being of residents throughout our state. I will state 3 reasons why we are concerned about moving to the federal exchange. First, MNsure is a one-stop shop for all consumers, and that is a clear advantage over the federal exchange. We have a partner in our coalition who also works in Wisconsin, and we have seen how healthcare.gov operates. There are different websites and policies for public programs and private insurance. Having different websites causes confusion for consumers and leaves some people in a gap between commercial programs and public programs. With MNsure as a one-stop shop, consumers benefit from just having one website to go to determine eligibility and enrollment. Secondly, Minnesota would lose flexibility and control if they went to the federal exchange. As the previous speaker mentioned, it's unsure whether we could really have Minnesota Care as part of our package going to healthcare.gov. Another area where MNsure has really succeeded is really that we have a robust statewide navigator program that does grassroots outreach and enrollment through local entities. A move to the federal exchange would undoubtedly reduce the level of navigator activity and result in inadequate levels of enrollment assistance throughout the state. And finally, with millions of dollars already spent to establish MNsure, we view dismantling the current exchange as a waste of government resources. MNsure is a functional enrollment platform which has experienced increasing enrollments every year. This last year was a record year for enrollment in both public and private programs. Dismantling an established effective tool for a lesser system is not good stewardship of public money. In summary, there has been great progress through MNsure in expanding health coverage to thousands of residents throughout our state. MNsure has now become a mainstay and accepted way to enroll in health insurance. We believe that moving to the federal exchange would be a definite step backwards for Minnesota. Thank you.
Thank you for your testimony. Welcome to the committee. If you could approach the testifier stand. Please state your name for the record, who you might represent, and provide us with your testimony. Thank you.
Thank you, Representative Albright, members of the committee. Thank you for having me here today. My name is Alyssa Peoples, and I coordinate the Healthcare Access Office at the Lake Superior Community Health Center, which has locations both in Duluth, Minnesota and Superior, Wisconsin. Jenny mentioned that I'm that partner. I'm here to talk to you today about the moving to transition from MNsure to the federally facilitated marketplace, and I'd just like to express my concern regarding the proposal, as my work as a coordinator has introduced me to both exchanges, which shows me the impacts of each system. Minnesota and our marketplace pride themselves on being a one-stop shop for all consumers. No matter your income or life circumstances, consumers know where to go and where to find assistance. We see this benefit through people with varying incomes and mixed households, where family members may qualify for different types of coverage based on different eligibility guidelines for adults and children. When looking at the federal marketplace, our Wisconsin sisters note frustrations with the policies and procedures for counting income, which ultimately leaves some people caught in a gap between approval for commercial health plans and Medicaid. Because the state-based electronic Medicaid application and the federal marketplace do not talk effectively, we see many people fall into this gap, struggling to be approved for any type of coverage. The gap and the inability to easily access coverage strongly affects the mixed eligibility households, people whose income is borderline between public and private programs, and self-employed people. We see that the issue of falling into the gap is greatly decreased in Minnesota based on our exchange. And the advantage of having the local control gives us the ability to communicate effectively between our agencies to ensure that all of the citizens of Minnesota have the care that they can access. Thank you.
Thank you for your testimony. Welcome to the committee. If you could approach the testifier stand, please give us your name, who you might represent, and provide us with your testimony. Thank you.
Thank you, Representative Albright, Representative Dean, and members of the committee. I'm Karen Wolter. I'm a MNsure navigator, and I am one of the faces of MNsure in the northeast part of Minnesota. I work for Community Action Duluth. I have been witness to Minnesotans having real conversations regarding current coverage as well as very anxious thoughts as to what the future might hold for them. A family who, without the monthly tax credit, knew they would go uninsured due to inaffordability. A woman with a spouse with a heart condition with medication needs stated to me, if anything changes and our costs goes up, we will not be able to cover me. We will need to cover my husband. I was witness to a young couple trying to decide if they could afford premiums for the two of them. The conversation came down to this: you need your medications and treatment for your mental health needs. I will go without. I have seen the following changes in the northeast section of our state: the growth in the number of people who have served, we have served since 2013 staggers me. Instead of seeing Minnesotans who have not had insurance for 5 to 15 years, the span has dropped from years to months. Trust relationships throughout Minnesota have been built and maintained between community organizations, local counties, state government, and the insurance industry. We can have 4 different family members under 4 different programs, and their coverage can be managed under one entity instead of 4. Minnesotans know, should they experience income changes for better or worse, they can easily move from one plan to another plan within the MNsure system. Insurance illiteracy is being replaced by insurance literacy, personal empowerment, and social responsibility. I see MNsure working for Minnesotans every day. I remember what it was like before MNsure. I do not want to go back to that place. Please afford Minnesotans peace of mind in knowing they can continue to see the state of Minnesota offer affordable insurance to all Minnesotans under the MNsure exchange, a system that continues to offer a familiar and trusted relationship. Thank you, Mr. Chair.
Thank you for your testimony. Welcome to the committee. If you could please state your name for the record, who you might represent, and provide us with your testimony. Thank you.
Sure. Representative Albright, Representative Dean, and members of the committee. My name is Laura Sales, and I'm here with the Minnesota Nurses Association. MNA is a union of almost 20,000 bedside nurses who work in hospitals all across Minnesota and parts of Iowa and Wisconsin. I'm here today to testify in opposition to House File 10, a bill directing the Department of Human Services to transition the MNsure eligibility system from a state-based system to a federally facilitated exchange. Our opposition to the bill rests on 3 issues. First, the MNsure eligibility system is also a one-stop shop for applying for public programs, not just for individuals buying health insurance or obtaining tax credits. This has helped reduce the confusion over whether you apply through the county for some programs or directly to DHS for other programs. Moving to a federal exchange would likely get rid of this feature of the MNsure system and could recreate the confusion that existed before the exchange was implemented. Secondly, if Minnesota moved to a federal exchange, we would not be able to administer the Minnesota Care program in the same manner. Minnesota elected to designate Minnesota Care as its basic health plan. As we understand it, the federal exchange does not have the ability to administer a state's basic health plan. So Minnesota Care, which is an important health care program for Minnesota's working poor, would likely have to move to yet another system, making it more inefficient and confusing to administer. Lastly, MNA is a supporter of local control where possible. Minnesota knows best what works for its citizens. Asking the federal government to administer our health care eligibility system moves the decision-making further away from Minnesota and increases the likelihood of confusion, mistakes, and frustration. For these 3 reasons, we respectfully oppose House File 10. Thank you for your time.
Thank you for your testimony. All right. And welcome to the committee. If you could make your way to the testifiers table. Please state your name for the record, who you represent, and provide us with your testimony. Thank you.
Good afternoon. My name is Brandy Clark, and I work with Med Eligible Services. I come to you on behalf of the 18 medical assistance specialists and all the clients that we assist utilizing the MNsure website. Med Eligible Services assists numerous clients each day in applying for medical assistance, either by completing the application with them in person or over the phone through the newly created Assister portal. Since the birth of the MNsure website, I've witnessed its growth and improvement in use of the ease of usage each year. It's a vital tool in our limited arsenal of assistance. The MNsure website is user-friendly not only for educated assisters, but for everyday people. All the benefits of the Minnesota website, from giving the definition of MNsure to helpful videos such as Health Insurance Explained, the latest news releases, in addition to the resource links, make people feel like their state cares. The clients love the fact that the online application takes roughly 30 minutes to complete, and they get an initial determination almost immediately, as opposed to the up to 60 days that it can take for paper applications to be approved. This is extremely helpful in cases where the patient needs immediate ongoing treatments and medications. The ease of the application, such as not letting clients proceed if information is missing, and the fact that the income area is pre-filled in many cases, helps the application process flow. I feel switching to a federally facilitated marketplace, the website seems cold and feels impersonal. I feel that the state of Minnesota cares deeply about their people, and Minnesotans deserve better than being lumped into a federally run marketplace. Thank you.
Thank you for your testimony. Is there anyone else in the audience who would wish to testify to the bill? Seeing none, we'll close public testimony and go to member questions. Representative Grunheim.
Well, thank you, Mr. Chair. Yeah, just I appreciate the testifiers. I think everybody here wants people to be able to access health care when they need it. I definitely do. But I do think that there's a few misconceptions out there about MNsure, and I could mention about 150, but I'll stick to one or two, okay? First thing I want to just address is that we have fewer uninsureds in the state of Minnesota. I agree with the testifier who said we had a 9% uninsured rate prior to MNsure and Obamacare. And today it's down to 4 or 4.3, depending on who you want to listen to as far as statistics. But at the time prior to MNsure that was stated in this committee, we had about 6% of that 9% eligible for a government program, but they had not signed up. So if we could have simply tweaked our current program prior to MNsure, we could have a 3% uninsured rate by getting those 6% to sign up for the government program they were eligible for. And we wouldn't have spent $400 million on MNsure, which a MNsure board member by the name of Tom Forsythe, when we had spent $200 million, declared to be madness to continue to spend this money on MNsure. So we could have a lower uninsured rate and have saved $400 million taxpayer dollars. The other thing to understand is that government programs reimburse doctors at hospitals for their fees. And this is going to make it more difficult for people on government programs to access the health care they need. Now, I had an orthopedic surgeon in my office yesterday from the Twin Cities here who said that I told him about the CEO of Mayo's comments, which were published, and he was heavily criticized for that Mayo's going to give preference to privately insured patients over Medicaid patients. And the orthopedic surgeon told me that the government is pushing them to a point where they're going to not take government health care reimbursement. So we've got to shrink and reform government reimbursement, not expand it, if you want to be able to access the health care when you need it in one of the best health care systems in the world right here in Minnesota. In fact, if we continue expanding government health care, you're going to damage one of the best health care systems in the world. So you've got to understand, government is not the answer, it's the problem. And if you want more detail, you can read my book I wrote on it back in 2010. Thank you, Mr. Chair.
Representative Pinto.
Thank you, Mr. Chair. One question I had for the woman who testified most recently, I'm not sure if I think she's over there. I wanted to ask how the website is. It sounds like she and clients work frequently with the website, and we've heard a lot about the MNsure website. Just wondering if she could just speak about how she's found the website to be working more recently.
Members, just as a reminder, as we look at the clock and what we've got left on the docket, we do have 5 more bills yet to complete if we don't want to come back yet this evening.
Representatives, Mr. Chair, I find it working wonderfully. I haven't had any problems. If we have a lifeline, which is the ARC, the Assister Resource Center, and it's a line that we can call and divvy out what's going on, and we're able to get through. So, you're welcome.
Thank you. I guess I had a similar impression from the other testifiers who work regularly with it. And then a question for Chair Dean, based on one of the other testifiers. Just wondering, so the one who receives Minnesota Care, so how will eligibility for Minnesota Care and for medical assistance, the healthcare programs for lowest income Minnesotans, how will they be determined if we have MNsure go to the federal exchange?
Chair Dean.
Excellent question, Representative Pinto. That's one of the things that Minnesota and New York are the only BHP states, so we're in a little bit of a different kettle of fish from that regard. But really, the way I think you have to look at it is when Gruber Gorman decided in their report how much business we would have through the exchange when they planned it, they planned for around 600,000 in between shop and the individual market. Obviously, that did not occur. So our individual market has, in fact, the bottom rusted out of that bucket. And that's what we're dealing with in Minnesota right now. So the proportion of people who are on individual private health insurance is very small. This is basically, MNsure is basically a public program with a little bit of individual market added to it that doesn't work really well. So what this does is it recognizes that and says that, and I think that our friends who are county caseworkers would embrace this decision that would just say, let's allow the counties to take care of people who are on public programs, and let's let the private people, if you buy private insurance, let's let those folks out of this box and into being able to purchase insurance and getting their benefits at the point of purchase. So what we would need is an eligibility determination system that just says, are you eligible for a public program or not? And that you would go one way or the other. Now, if this one-door concept with many doors on the other side sounded great, for sort of a Travelocity or Expedia choice for healthcare, and you could imagine William Shatner selling insurance policies on television. That's the way it was kind of sold to us. It didn't really work that way. So what we are trying to do is figure out a way for, we deliver program care through counties to allow the counties to work that better. So that sort of the diamond is, are you public, yes or no? And if you are, you are diverted to the counties, who would then operate the Minnesota Care program within that, as they do Medicaid, to that, so that would be the door that you would go to. And so that's a very simplified explanation of how that would work, but very clearly the process that we currently have doesn't work for the families, it doesn't work for the counties, and it doesn't work at the state level either.
And Mr. Chair, and so Chair Dean, so who would pay for, so it sounds like you're talking about there need to be a new eligibility determination system created and all that with the county, so who would pay for that? Where would the funding come for that?
Chair Dean.
Well, that, Representative Pinto, that's kind of the question that we've been asking when we've been talking to people around the state is, how far down do we have to dig before we get to bedrock as far as IT goes? Because what we want at the end of this thing is we want a system that works for our county caseworkers, that's functional, that they can operate, that works. They are anxious. They're anxious about this idea, because I would be too if I were them, because they've just had the rug pulled out from underneath them and had to put things together with duct tape and baling wire for the last couple of years. And they're on pins and needles, and they're giddy when they get a new widget so that they can do another workaround that actually saves them some time every day. So those folks really do deserve an IT system that actually works. And I think when you look at the other states that have done that, we're going to have to invest some more money in order for that to happen. But the question of how far down we have to dig to get to bedrock, I don't know yet. But I do know that the folks are out there who've done that in other states can tell us that some states you have to dig further than others. But that is one of the things that we have paid a lot of money for. And we don't want to throw all of that out with the bathwater, but we need something that works at the end of the day.
So, Mr. Chair, I'll be respectful.
Pinto.
Thank you, Mr. Chair. I'll be respectful of your point about time, so maybe rather than asking more questions, I'll just kind of put in a comment then. So to be sure that folks are clear, my understanding is the MNsure right now kind of does serve these two purposes of connecting people with the individual insurance market and then also eligibility for public programs. And as I heard Chair Dean speak, it really is much more, it sounded like you're saying, much more the public program piece at this point, very little in the individual insurance market. So I just understand this proposal is to take that little piece that's individual insurance, we're going to hand it off to Washington and the feds, where we've got all kinds of uncertainty and problems there. We're mostly left, though, most of MNsure, the Chair Dean has said, is about the public programs. We're then going to create a brand-new eligibility determination system, taking the good money that we've put in, the concerns about that, with a website that we're hearing is working very well. We also hear some concerns as well. We're going to then apparently trash that, create a new, or build on it, pardon me, a new eligibility determination system we're going to have to pay for. We take all the disadvantages of a Minnesota way, a one-stop shop, and all that. So I guess I'm confused that if MNsure is so much about these public programs, then I'm not sure why we take this small chunk of individual insurance, hand it off to Washington, and we've still got to deal with the people who've testified and making sure that people who are low income can have the health care that they deserve. So I have great concerns about this, and I'm sure we'll continue to explore it. Thank you, Mr. Chair. And Mr. Chair.
Haley.
I just wanted to clarify about the public portal, and Chair Dean, his testimony did that.
Representative Schultz.
Thank you, Mr. Chair. So I just don't want to confuse MNsure with METS. So when Representative Dean came to St. Louis County and we met with our workers who do eligibility enrollment and some navigators, we need to improve the METS system, which we use to determine eligibility and enrollment into our public programs. MNsure is just a portal that makes it easy for people to connect to resources. And if we move to the federal exchange, we're going to really confuse Minnesotans on whether or not if they go to the federal exchange and they don't qualify for a QHB or federal plans, then they may not know they qualify for public programs. So I think it's just going to lead to more confusion. The Healthcare Finance Task Force, bipartisan group of 29 individuals, different stakeholders in healthcare, concluded with information from experts that are unbiased about the expense of going to a federal exchange, which is over $5 million. We don't have any control of the federal exchange. The fees could go up at any time, any year, to use the federal exchange for this small group of people. Right now, there's so much uncertainty at the federal level that I don't know why we would want to give up this local control of our exchange when it's working much better than it has in the past. It had record enrollments. It had about 60,000 new enrollees, and they had to do it in a very short time frame with very short call times. They've improved, and they were a success. If it's such a disaster, why did they have such a successful enrollment period this last year? So it must be working. And the level of uncertainty with at the federal level, I would think we'd want more control. And just if you remember historically, it was the Republicans that wanted states to create their own exchange, going way back. And we did that because we wanted state control. And now, Representative Dean, you're saying that we should move to a federal program, have the federal government control our exchange. I just don't think that's what you wanted in the past, what your group wanted in the past. And in fact, last Wednesday on Almanac at the Capitol, you said that you don't want to follow Washington, D.C. anymore because they're really bad at this. So what has changed since last Wednesday when you decided that you don't want to follow what Washington, D.C. is doing? because Minnesota is better at doing things, and we are a leader in healthcare. So what has changed your mind?
Chair Dean.
Mr. Chair and Representative, I was referring to how to deliver health care, and whether this was originally a Republican idea or a bad idea, I don't know. I just think it's a terrible idea. And it's one that we can't continue to operate. I'd ask you, how much state resources are you willing to continue to put forward to prop up MNsure, even though we have absolutely no statutory authority to set their budget? They are completely autonomous from us. MNsure can send a bill to DHS, and we have to pay it and build it into our budget. I don't think that the Healthcare Access Fund or our general fund should be used as an overdraft account for an unaccountable bureaucracy.
Well, Mr.
Representative
Chair,
Schultz.
thank you. I take issue with the budget of MNsure. I think that they do have a projected forecasted budget that is self-sustaining because they are collecting premium withhold revenue that they expect to increase. And in their budget, they have been able to sustain themselves without federal funding that's forecasted. And the money that they're using, the state money, is actually going towards improving the MET system. And we would need to continue state funding for METs if we want to continue our public programs. So if we eliminated state funding, then I'm guessing that you might want to eliminate or pull back some of our public programs. But a lot of that funding, and maybe we can have someone from MNsure testify about their budget so we get accurate information.
Response, Chair Dean.
I would just say that if you would like to spend the state subsidy that we're currently giving to MNsure on their administration and overhead on programs that take care of disabled children or orphans or any of the other folks that we prioritize in this committee, I would be happy to vote for that myself.
Representative Murphy.
Thank you, Mr. Chair. I'd like to begin by asking the chair of MNsure to come up to testify. I think that there were 3 points that Chair Dean made about why we're here, and one is about MNsure's self-sufficiency. We're going to disagree. I think Chair Dean and I are going to disagree over the interagency agreement between MNsure and the Department of Human Services and the work that they're doing through one common entry point, and why DHS is paying MNsure for some of the work that they're doing, and there's an exchange of funding that is legal, and we've litigated that in this committee before, and I don't think we need to debate that again. We just are going to disagree on the validity of that and the purpose of that, and I think MNsure and DHS are doing something that is upfront. But I would like Mr. Benner, Chair Benner, if you could, to just make sure you have on the record for us what is the state of the budget and your self-sufficiency going forward, so we have that as a part of the record.
Mr. Benner, welcome to the committee. If you could identify yourself for the record and make the response to the question.
Thank you, Mr. Chairman. My name is Peter Benner, and I am Chair of the MNsure Board. Mr. Chairman, Representative Murphy, the budget the MNsure Board adopted earlier this month is balanced, it is self-sufficient, and it will be balanced and self-sufficient going into fiscal 18 into fiscal 19. We bill back the Department of Human Services for services we perform on their behalf. The billing is based upon the cost allocation formulas that DHS by federal law and state law has to engage in on that matter. But every nickel that we receive from DHS is for a service we have provided to DHS.
Follow-up, Representative Murphy.
And thank you, Mr. Chair, and thanks, Mr. Benner. So to the point of MNsure's self-sufficiency was just one of the tests of the Affordable Care Act. Can you just let the committee know, so going forward, right, that you need to be able to support the operation of MNsure
Yes.
going
Mr. Bennett.
forward, right?
Yes.
Can you just make sure we understand where your budget is in terms of that?
Mr. Chairman, Representative Murphy, going forward, our budget is entirely dependent upon the premium withhold we receive, and that is based on the premiums paid by Minnesotans who enroll through the MNsure website in a qualified health plan. By state law, federal law, we are required, that's our only source of revenue, and we are required to make our budget balance so that we can survive within that revenue, and we have done that in the past, we're doing that in the future.
Thank you, Mr. Chair, and thank you, Mr. Benner. I appreciate you coming up and putting that on the record for us. And then, I'll just say, the debate this year and in the years past have been around healthcare become so polarized and hyperbolic, and so I'm trying to lead by example and not engage in that while expressing my strong concern about this piece of legislation. Given the uncertainty, really the crazy uncertainty, if anybody here could say what the heck is going on right now in Washington. Tomorrow they're going to take up a repeal of the Affordable Care Act. It is the anniversary of the Affordable Care Act. I don't know that they have the votes to do it. I don't know what's going to happen. And at the same time, we would say, okay, Minnesotans, you head out that way. We'll send you out that way. And you get your stuff there. That seems, given the swampiness of DC right now, that seems not in their interest. So I again, really trying not to be too rhetorical, but this is just not a direction that I think the state should be going.
Representative Franzen.
No, we're good.
Representative Liebling.
Thank you, Mr. Chair. Well, so here we are talking about repealing MNsure. And, MNsure and Minnesota Care, a lot of the terms are really confusing to the public. And I like to make sure that people understand that MNsure is this system for buying insurance. And Minnesota Care, as we heard wonderful testimony here from one of the people that came down from Duluth, Minnesota Care is a program that we've had in Minnesota for about 25 years that has provided excellent health care to low-income working families, for the most part, and people who pay premiums for that program. So what we're looking at here, we're talking about MNsure, the system, but it does intersect with Minnesota Care, as has been noted. And I think it's important to note, and Representative Dean, correct me if I am wrong, but you have also tried to get rid of the Minnesota Care program. So I know that preserving that program is not a priority of yours either. MNsure, the system, has really been a favorite whipping boy of Republicans now for quite a few years, and has been used as sort of an emblem of the Affordable Care Act. You know, we hate Obamacare, so MNsure, 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 how terrible it is, what a disaster it is. They've even said that it's killing people. All rhetoric. We know it had some challenges getting off the ground, but right now, where are we as a state? Right now, we are looking, as Representative Murphy said, we are looking at the federal government, Republicans who are in control in the House and Senate and the presidency in Washington, D.C., are going to make big changes in health care. And what we have seen, the bill they are trying to pass, we know from independent Congressional Budget Office that millions of people will lose insurance under that legislation if it were to pass. And I think the number is 24 million people. And that will include people here in Minnesota. In addition to that, there will be cuts to Medicaid, which gives us many billions of dollars that we use here to fund health care for low-income people, but also for people with disabilities. So we are facing a huge unknown, and it is not a pretty picture. And so at the very moment where we are facing this, Republicans want to repeal our MNsure program and send Minnesotans to the federal government website now under the control of Republicans who've been hating on that too for years. So we are really at a moment of peril. Besides that, I don't know if the intention with this bill is to save a bunch of money so that we can meet the cut target that Republicans have put forward for this committee. But the budget for Health and Human Services in the Minnesota House is to cut, I think it's $600 million from our current forecast spending. How are we going to do that? I don't know what we would potentially save from the bill before us because we have no fiscal note. That's certainly not Representative Dean's fault because I guess one's been requested and sometimes they're slow in getting, the fiscal staff is kind of nodding. And we've had trouble catching up and getting all of the fiscal notes, which are our official estimate of what a proposal is going to cost or save. So we don't know what this would save. But from what I'm understanding from the gentleman who just testified from MNsure, this is probably not going to save anything or much of anything in our state budget. So here we are with a bill that's not going to save us money, that's going to send, even though it is not perfect, I think everyone on this committee, on the Democratic side, we would all acknowledge that it's not a perfect system. It still needs parts built out. It's still being worked on. But it does intersect with our public program eligibility. That's this METS term that we are throwing around here, is the public program eligibility piece of that. It's kind of confusing for folks. When you go to MNsure, depending on your financial information you put in, you get directed into the public program eligibility piece or the private plans piece. So that's what we're talking about here. Eligibility for public programs. Anyway, at the very moment when we're facing this peril as a state, and other states are facing it too, Representative Dean wants to get rid of something that is working, that's helping a lot of Minnesotans, that helps to support our Minnesota Care program, and just send Minnesotans off into the unknown to deal with the federal government and whatever they're going to be doing to that system in Washington, D.C. That is a very, very concerning thing. I think it's a really reckless idea at this particular point. Representative Dean mentioned in the beginning that this is the same bill he had before. We are not in the same situation we were before. Not in terms of MNsure and where that is, and certainly not in terms of what healthcare is looking like coming down from the federal government and what the federal exchange might look like. We just do not know what will happen to that. So this is a very concerning thing. I think that this is a time when we ought to be kind of holding our breath and waiting to see what is going to happen to us before we go forward and make big changes on anything, frankly, because we simply do not know what resources will be available. So I hope that helps clarify this a little bit for the public. One additional thing I do want to say, and that is we're often hearing right now from the Republican Party about how wonderful things were in Minnesota before the Affordable Care Act. And to be sure, we in Minnesota did a lot of things better than a lot of states, and we have prided ourselves on that. One of the things was our Minnesota Care program, which we were able to maintain under the Affordable Care Act, and it's undergone some changes, but it's been an important part of what made Minnesota very special. And through my time that I've been in the Minnesota legislature, even before the Affordable Care Act, Obamacare, Minnesotans really wanted people to be covered. Minnesotans really care about everybody having access to health care. We should be focusing on how to do that. That should be a bipartisan priority, making sure everyone has access to health care. Not that we have an insurance market, not even that people have insurance, but that people have access to the care they need when they need it, at a price they can afford. I hope that we can make that our goal and see how we can get there the best way, not hate on MNsure and just make political points with that. Thank you.
Representative Loeffler.
Well, thank you, Mr. Chair and Representative Dean. I'm concerned about the interface with the partnership that we have now, which is an integrated access point for people to find out what is the best deal for them. That was always the best goal. The goal was that people who were going to pursue private insurance because they make too much money, they know they don't qualify for any kind of public subsidy, could compare and contrast plans with equivalent data to look at. But they could also without knowing it, and I heard this from constituents, they put their data into the system, the MNsure system, and went, oh my gosh, I qualify for Minnesota Care, and this is so much more comprehensive and affordable than I could ever have imagined. Or there's someone who's been on Minnesota Care, but because they've gotten a promotion or a change in hours or overtime or something, all of a sudden they have to switch back onto private coverage. And having it all in one system has allowed people to make that seamless transition back and forth from eligibility from some public subsidy of premiums to not, whether it was federal subsidy or state subsidy. It has allowed people to make that decision. And I heard you say, if I heard you correctly, that, well, people will just go on and they'll ask, are you public programs or private? And if you're private, you'll go to the Washington, D.C. site, and if you are public, you'll send to something in Minnesota, and you kind of implied it might be something new. And yesterday, we were talking in this room about the green and black screens that are the current eligibility system in Minnesota. That's DOS programming with a 1990s update that we are partway through the very heavy lift to get to a modern technology platform for determining eligibility in all the 87 counties. And I am here, and we're using and taking advantage of federal money provided for the exchange to help pay for some of that modernization. And part of that is because of Minnesota Care being a BHP, as I understand it. Part of it is part of the built into the ACA. I'm concerned that if we go this direction and pull our private people out onto the Washington, D.C. exchange, that we're going to jeopardize the ongoing funding and the work that's been done now to upgrade our eligibility system and our ability to have that mostly seamless handoff back and forth as people's life circumstances change. And I'm wondering if you could expand a little bit more about, have you gotten, what do you know about the federal money that's currently supporting the transition to upgrading and streamlining our eligibility system for both Minnesota Care and medical assistance, and how that would continue or not under your proposal, or if you think we'd have to start again, and with what kind of state resources would that take, what kind of county involvement. I have heard from the counties that they have really appreciated Representative Zerwas's efforts last year that got them on the executive committee of MNsure. They really feel like their priorities have been paid attention to and are moving along. So if you could just bring us up to speed on what you know on both finances and the route forward, that would be helpful.
Chair Dean.
Could you repeat the question? No, I'm teasing.
Sorry.
No, your question regards how we can really look at what the counties are going to do moving forward, and that's really, I think, needs to be the hub, and the hub of the wheel needs to be the counties. This thing has to work for them, and I think we have to build it around their needs, and the technology platforms need to react to that. I think anybody that says that the initial design and implementation of MNsure has been good or has been effective or has done what it was promised that it would do, I don't think we can agree on that. But sometimes I just feel like, you know, that the picture of the striped dress that was, half the people who saw it was blue and black, and the other people saw it was white and gold. And I think if people are watching this committee right now, they're thinking, those people are looking at a different dress than I am. You know, this is the weirdest thing I ever saw in my whole life. I don't understand what they're talking about. They can't be talking about the same thing. And we kind of are in that zone a little bit, I think, some of the time with this. And, you know, for real people out there who are trying to get health insurance, particularly in the individual market, this has been a nightmare. They've been signed up for Medicaid when they didn't want to get on Medicaid. They couldn't get off it. They had liens on their houses. They couldn't go backwards. They couldn't get to the doctor. They're issues that we have all dealt with our constituents within this. Now, if you're on a public program, you're retroactively eligible for Medicaid. You're immediately eligible for Minnesota Care. You have access. I understand that there's people who like to do public outreach for public programs, but that's not what this was supposed to do. This was never supposed to be a public program signer-upper. This was supposed to be a way for people to get health insurance. And if that's not what this is, we need to redesign it to reflect what it actually is. And if it's a public program management tool, why is it outside of our purview in the Health and Human Services Committee for our budget? I don't understand that. If it's their job to manage public program enrollees, why aren't they here? So that's kind of a basic question. I think it's our job to answer that question.
Representative Loeffler.
Well, thank you, Mr. Chair. And just to give you a shorter follow-up, I mean, it was always known that the majority of people on this would be public program users, and the Grumman, whatever projections confirm that in the early planning. And I'm glad to hear you say that the counties and an operational system for them is key. But I also heard you say, and we need to build from there. And my question is, are we going to build from the ground up? Or are you, and start over with all the work that's been done the last few years and being implemented across the state in 87 counties? Or are we continuing on, and what is the finances that you expect to support that work either way?
Representative Dean.
Mr. Chair and Representative Loeffler, we are budgeting to spend state resources in the tens of millions of dollars just for, if you look at MNsure's budget, transfers from our budget to theirs for overhead and operations. So we are on the hook for tens of millions of dollars from here on out, no matter what we do. Cook County, Minnesota has, I think, less than 5,000. Olmsted County, where Representative Liebling is a little over 100,000. In the city of Rochester, we've got Ramsey and Washington and Hennepin counties that are very large. They all have different needs, and we need to understand that the people, the saints who are going to be distributing care, that know the families, we need to really build a system around them. And I think that that's where the RFP outreach should be going right now, is not to how do we fix what's broken at MNsure, but how do we help people who are at the counties that need to help people on public programs.
Representative Loeffler.
Thank you, Mr. Chair. I still have grave concerns that this is a path forward that doesn't really address continuation of the work that's been done and address the fiscal risks that we have in having to develop our own system with our own state resources without the federal partnership we've had, and perhaps the fiscal note that comes eventually will give us some insights. Thank you.
Representative Hamilton.
Thank you, Mr. Chairman. And my question might be directed to the MNsure rep. And we heard the conversation around the budget and ongoing operating costs of MNsure. I would like to know what the budget and operating cost is of METS. So I don't know if you're the person that can actually comment on that. If you please come forward. And I've served on this committee for a number of years. And when MNsure was first launched, we only talked about MNsure until it stopped working. And then all of a sudden, we started talking about MNsure and METS. And MNsure was the good part, and METS was the bad part. And then we were told, my recollection, that METS was an IT system. That's all that METS did, was the IT portion of it. And now today I'm hearing that METS is the public program piece. So one, as a legislator, I'm seeking a little bit of clarification on what is METS actually. And I'd also like to know what is the ongoing operating cost of METS, because it's my understanding that DHS, they will pick up 90% of that cost, whatever that cost is. And I'm, as a legislator, do not know what that cost is.
Welcome back to the committee, Mr. Benner.
Mr. Chairman and Representative Hamilton, I am probably the wrong person to ask this question of. MNsure, part of the MNsure budget, and I do not have it in front of me today, does have an appropriation for our operational costs of the MET system. That is in the several millions of dollars. And that is our share of just the day-to-day operational costs. We also have some development costs in there going forward. Again, that's in the several millions of dollars. 7 figures, not 8 figures. The rest of the cost of METS is essentially DHS, because it is the platform for all the public programs, the interaction with the counties, a lot of other things too. And you would need to ask representatives from Human Services or Minute to talk about their piece of this.
Representative Hamilton.
Well, thank you, Mr. Chairman. And so I would like to have that answered, if not today, but going forward, because the ongoing cost of MNsure, we have to include the cost for METS, because until MNsure was no longer working properly, we didn't ever talk about METS. And now all of a sudden, METS is the issue, and that's where all the dollars go. However, we do not know, at least I do not know, how much money we are talking about, because in my mind, that METS component is, those costs should be allocated to MNsure too.
Welcome back to the committee, Mr. Morocco.
Thank you, Mr. Chair and Representative. So I'll see if I can answer the question. So METS is a shared IT platform by which both DHS and MNsure are making eligibility determinations. The previous testifiers had talked about the no wrong door, or one system that can determine an eligibility for Medicaid, 0 to 138%, for Minnesota Care up to 200%, tax credits from 200 to 400%, and then QHP at 400 beyond. So we have within the METS IT system a lot of shared functionality, but we also have functionality that is exclusive to our representative programs. So for example, once the eligibility is determined, it then for DHS becomes a case management system. And that is where both DHS is managing Minnesota Care client accounts, and the counties are managing the MA client accounts. So there's a lot of functionality within METS. The initial functionality is to determine eligibility across the programs. That would be an example of shared functionality. But once it gets into, let's say, determining somebody's eligible for Minnesota Care, and we are doing a Minnesota Care renewal, well, that would be functionality that's just specific to us at DHS. So MNsure as an agency doesn't necessarily have an interest in the build-out or the functionality of Minnesota Care renewals, because it would be a function that's specific to us. So again, it's an IT system where some of the functionality is shared, some of the functionality is exclusive to each agency, and that's where the cost allocation piece comes in. So where there's functionality that we duly share, then the cost allocation is generally representative of our populations. Medicaid being larger than the QHP APTC population, we're going to pay a larger portion for that functionality. But if they have exclusive functionality, we're not going to pay for MNsure's functionality, nor are they going to pay for our exclusive functionality.
Mr. Chairman.
Representative Hamilton.
Thank you, Mr. Chairman. To both of the testifiers, what is the actual cost of the MNsure program?
Mr. Morocco.
Mr. Chair and Representative, so you're saying the MNsure program. So MNsure is an agency, METS is the IT system.
Mr. Chairman.
Mr. Hamilton,
When we're
Representative Hamilton.
thank you, Mr. Chairman. When we are talking about MNsure, part of the MNsure system is the IT portion of it as well. That's how it was discussed years ago. That's how I am discussing it here today. When we take into consideration everything it takes to operate MNsure, what is the actual cost of the system?
Mr. Benner.
Mr. Chairman, Representative Hamilton, in the budget we adopted in March for fiscal 17, let me try to do this. Let me try to do the MNsure piece of this, and then Mr. Morocco can talk about the overall piece of this. For fiscal 17, for operations, MNsure itself spent $3 million as our piece of the operations of METS. For fiscal 18, we are budgeting $3 million for our piece of the operation of METS. For fiscal 19, if we ever get that far, we are budgeting $3 million for the operations of METS. So that's our piece of the day-to-day operating cost, reflecting both the parts of it that are exclusive to QHP enrollees and our shared part of where both we and DHS have a shared platform. Nathan?
Mr. Morocco.
Mr. Chair, and to Representative Hamilton, unfortunately, I only have the fiscal year 19 numbers, but it sounded like the MNsure portion was roughly the same across those fiscal years. So the current METS operating budget for fiscal year 19 is roughly $32 million. The funding sources would include about $21 million that come from federal, about $8 million that come from state appropriations, and then the premium withhold that comes from MNsure is worth roughly $3 million.
Representative Hamilton.
Thank you, Mr. Chairman. And to that point then, we're talking about approximately $3 million in the operating budget for MNsure. However, I'm under the impression that DHS is going to pick up 90% of the cost, whatever that cost is. How can you assure us that other portions of DHS are not picking up additional cost of the operation of MNsure that's taken monies away from many of the people that you see in the room here today?
Mr. Morocco.
Mr. Chair, and to Representative Hamilton, so, we've talked about the cost allocation process that we have with MNsure. To the extent that more clients are coming through the MNsure door, we are then picking up proportionally and appropriately so the cost of doing so. That would be independent of whether MNsure were here or not. If DHS had its own IT system and it had its own IT needs, and through the expansion of the Affordable Care Act, or just through any means by where more people or more activities occurring on the system, we would incur those expenses regardless of whether we're sharing an IT platform or whether we have a standalone platform. And that's no different than our legacy systems. We continue to do build-outs on our MMIS and our Maxis environments, as well as all the various IT systems that we have. So I can't provide a specific guarantee on that because the costs are relative to the activity and the demand that's occurring on those systems, and that's what the legislature is asking us to do, is to manage, the expectations of the needs of the program relative to the appropriations that were provided by the legislature.
Follow-up, Representative Hamilton.
Well, thank you. And Mr. Chairman, this is where the frustration comes in. And, fall of 2015, I had a mother and two children that were kicked off of insurance because they were told by the agent through MNsure that MNsure was not Apple compatible. This is how frustrating this has been over the years. So, thank you, Mr. Chairman.
Representative Considine.
Thank you, Mr. Chair. Representative Dean, I think we can all agree that stuff that's going on in Washington right now is bat stuff crazy. and I don't really think we can count on anything coming out of there. So if we pass this and you're successful in dismantling MNsure, now that it's finally working right, what happens if there is no federal exchange? What do we do then?
Chair Dean.
Mr. Chair, Representative Considine, the folks who are on public programs would receive their care exactly the same way they do now, which is through the county-based delivery system, and people who would be on QHPs, if that program goes away, we'd have to look at what happens on that side. But that's really what this is trying to do, is address the fact that this has basically become a public program.
Representative Considine.
I'm good. Thank you.
Representative Murphy.
Mr. Chair, I just want to make sure that we call for a roll call vote, please.
Roll call being requested. Clerk will take the roll. Chair Dean, final thoughts.
I would just encourage members that as you bring bills forward, be aware of the time and manage your bills so that we can get all of our bills done by the end of the time. I just really want to apologize for taking up so much time with my bill. I'm really sorry for that, but I think it is a good discussion that we've had regarding this. It is a very important thing that we're going to be dealing with. And if this is not successful, it doesn't pass this year, I'm going to guess that the next legislature will be dealing with this, and that middle-class Minnesota is in a vice, and they aren't able to solve their problems through MNsure. And I think that the way that we're paying for it, currently MNsure can fund itself by billing another agency, and I think that that is a faulty way for us as a Health and Human Services Finance Committee to give up our oversight of that. I think is not good, and that long term we need to bring that back under our control so that we can better deliver services to the citizens of the state.
With that, Chair Dean renews his motion to lay House File 10 as amended over for possible inclusion in the Health and Human Services Finance Omnibus Bill. A roll call being requested. The clerk will take the roll.
Chair Dean.
Yes.
Representative Albright.
Yes.
Representative Murphy. No. Representative Allen.
No.
Representative Backer.
Yes.
Representative Considine.
No.
Representative Fisher.
No.
Representative Franson.
Yes.
Representative Grunhagen.
Yes.
Representative Haley.
Yes.
Representative Halverson.
No.
Representative Hamilton.
Yes.
Representative Heintzman.
Yes.
Representative Johnson.
Yes.
Representative Liebling.
No.
Representative Loeffler.
No.
Representative Lomer.
Yes.
Representative Lunan.
Yes.
Representative Pearson.
Yes.
Representative Pinto.
No.
Representative Schumacher.
Yes.
Representative Schultz.
No.
Representative Zerwas.
Yes.
There being 14 ayes and 9 noes, the bill is laid over for possible inclusion in the Health and Human Services Omnibus Bill. House File 1132 and House File 481 will take up Representative Kiel's bill first, 481. And as she's making her way towards the testifier's table, I'll move House File 481 before us. I don't see any amendments, Representative Kiel, so to your bill.
Mr. Chair and members, I apologize. I heard Chair Dean's command about being precise and
Brevity is
timely.
your friend, Representative Kiel.
Members, House File 481 is a bill that addresses personal care assistance. It's to help people with disabilities to live at home by assisting with dressing, eating, toileting, bathing, grooming, and transferring out of bed into a wheelchair. Some individuals require more complex assistance with respiratory issues, feeding tubes, and other medical needs. Members, it's been a long time, but in 1978, the PCA program was created. And this bill would require that anyone that is asking for 10 hours or more of personal care assistance receive a PCA that is not only trained in just the basic care, but more complex care, so that in the end they can be reimbursed at a higher level. With me today is Mr. Jeff Bangsberg, and I would like him to testify.
Welcome to the committee, Mr. Bangsworth. If you could state your name for the record and provide us with your testimony. Thank you.
Thank you, Mr. Chair. Members of the committee, my name is Jeff Bangsberg. I'm an advocate on behalf of people with disabilities throughout the state of Minnesota, and I'm here on that behalf today. We do have a severe shortage of personal care assistants throughout the entire system. Over 40,000 people are on the personal care system, and we do support a wage increase for all personal care assistants throughout the state. However, I'm here today to talk to you about those individuals who are at the highest level of care needs that are in need of care today, and some of them are in the room before you. These individuals have had a more difficult time finding caregivers, particularly because there have never been a differential in pay between people who have lesser needs and have lesser type of observation or oversight versus individuals who need constant attention every day, every minute of the hour, and almost is a life or death situation in some of their situations. Again, these people do live at home. They are with the most complex needs, and it is very difficult to do this when you're paid between $10 and $12 an hour. And as it was stated in the legislator's auditor's report, that fast food jobs pay more than this, and it's very hard for these individuals to continue to live in their own homes. And many people with disabilities who receive these services are employed. In fact, Carla Fries, who was here the other night, is working, and that's why she cannot be here today. Or employable, and they are able to become employed in the workplace. The lack of the appropriate care has led to severe pressure sores, breathing problems, and urinary and other infections. People have been left over bed in holidays overnight, and we have one member here today who was that individual that Carla Fries referred to that was left in bed over Christmas because she did not have a caregiver that day to get her out of bed. Don Banya is not here today because his caregiver is sick. However, she's still providing care for him in his home today. She can't even take the time off to be sick because she has to care for this individual who needs constant supervision, constant help. He cannot feed himself, he cannot move his arms, he cannot drive his car. I used to be in the personal care assistant program, and when I qualified for 9 hours of care per day. I can move my arms, I can't use my fingers, but I can drive, I can still feed myself, and on some good days I can wash my face. But basically what I'm talking about are those that are higher level than I am. And those individuals really are having a more difficult time, especially when the economy is as good as it is. It's much more harder to find caregivers that are willing to provide care for these individuals in their own homes. Again, these are people living in their own homes, in the communities all over the state. So therefore, again, this bill would allow for training to be enacted, and the training would kick in July 1st of 2018. However, we do have language before that time to make sure that the individual is kept up to date with the care plan and that the individual is fully aware of what is necessary to be able to complete those care plan needs. And right now, the program is allotted for 10 hours of care, although the Department of Human Services defines complex care at 8. we realize that that is probably going to be much more expensive. We're talking about 3,000 people under this bill that qualify for 10 hours or more care per day. Thank you for your time.
Thank you for your testimony. And Representative Kiel, do you have another testifier today?
I don't, did you want to speak?
Yeah.
Okay.
Welcome to the committee. If you could just state your name for the record, and we welcome your testimony. Thank you.
Hi, thanks for your time. My name is Colby Smith. Currently live in Minneapolis. Closing in on the completion of my grad degree in vocational rehab counseling. I guess starting on that note, I really should have my degree completed already as of 2013, but whether it was a combination of health complications or, as this bill is raising the issue, is PCA services. Not only is it a struggle to find PCA staff, it's equally as hard to find qualified people. And I once had to withdraw from a class because taking a take-home exam, and my PCA that I didn't really care for at the time, she passed out because she was smoking pot by the window. With the struggles with PCAs for the past 10 to 12 months, my dad is probably, he's 70 years old and has picked up over half of my shifts. And as Mr. Gruenhagen can attest to, driving to and from the cities from Hutchinson, Minnesota is at least an hour and 15-minute drive. And he doesn't get compensated for those driving miles. And on this, separate from this bill, with looking at trying to get full-time employment, it's not just a matter of staying in my home. I have significant concerns about being able to attain and maintain full-time employment and not having to compromise both my short-term and long-term health. And part of that is also attributed to DHS assessment criteria, basically not taking into account all of my healthcare needs at a point that I actually find rather negligent. And I plan to be meeting with my Representative Dietzick on how to shore up that part of DHS. In closing with this bill, sorry, I just lost my thought. When I look at what could be potentially be happening at the federal level with what Trump's proposal, budget proposal, along with the establishment GOP looking at wanting to cut Medicaid, Medicare, and Social Security, it's giving me real concerns that in terms of Americans with disabilities, we could be reverting back to the days when my fellow Americans with disabilities were simply put back in institutions. And ironically, it happened what's happening the same time Hitler was doing the same thing at a more aggressive rate with his eugenics practice. The only difference here in America, people with disabilities weren't subjected to gas chambers. So my hope is how well Minnesota has taken care of people with disabilities. Whatever happens at the federal level doesn't complicate all of you here as representatives. And with my concerns of America going that route, I feel my grandfather's probably kicking in his grave after serving in World War II, that I am actually come to the position where I feel I need to explore the possibility of safe haven in another country, and my research is showing me that moving to Canada would be a 5-year stay, then be a citizen, and $5,000. And the reason I get this feeling my quality of life may be better there is their government recently just allocated $1.5 billion to help businesses become more accessible. And the last thing I have to say is that in Trump's inaugural speech, he said that the forgotten American men and women would not be forgotten. I think he was referring to working class people. And the truth of the matter is that the true forgotten American men and women are those of us with disabilities. That's my opinion.
Thank you for your testimony. Representative Kiel, you have any comments? Questions from?
Go ahead.
Questions from members? Representative Kiel, last word.
Members, I know you just got the fiscal note that I just received about 12:15 today, and was a little concerned about the numbers on there, something we're going to have to address and look at. But in light of that, there are some concerns, but I want us to really think about the fact that people who are requesting personal care assistance, especially those with 10 hours, are still trying to be productive citizens, to be able to do what they can to be independent and live in their homes. And I believe that the statistics show that it is cheaper to live at home and hopefully with your families. But with that, I would hope you would consider supporting House File 481.
Thank you, Representative Kiel. With that, House File 481 is laid over for possible inclusion in the Health and Human Services Omnibus Bill.
Thank you.
Thank you.
All right, thank you. And we are just going to complete the final bills. We have, capital investment is not going to meet, and so rather than coming back later this evening, we're going to conclude the bills. Representative Backer moves House File 1132 be held over for possible inclusion in the Health and Human Services Omnibus Bill. All right, Representative Backer moves House File 1132 be held over for possible inclusion. There's an amendment in packet being offered by another member. Representative Backer, to your bill.
Yeah, thank you, Chair and members. This bill does make one simple change. We remove the word constant. That is a very important change for individuals with mental illness. A couple years ago, mental illness, they changed the statute to put in the word constant. The challenge with that is we have residents in Minnesota who can live on their own, but they need a little direction or a little help each day. Putting the word back in, we would roughly help 1,830 people become eligible for PAC services with that simple word being removed. And it would save the state money because we may have someone that needs to come in and just help prepare food, help with bills, help with mail. And so I would ask for your support there, members. And we do have a testifier.
Welcome to the committee. Please introduce yourself and proceed.
Thank you. My name is Ann Henry. I'm with the Disability Law Center at Mid-Minnesota Legal Aid. And I'm here on behalf of our office and Sue Abderholden from NAMI, who couldn't be here. We just have strong support for the bill. I know a lot of you are familiar with it, so I would be happy to answer any questions regarding the removal of the word constant. It simply prevents people who don't need physical supervision from getting the help they need to remain independent. Thank you.
All right. Thank you, Ms. Henry. Are the questions for Ms. Henry? Representative Loeffler.
Thank you, Mr. Chair. And it sounds like what you're describing is what was known as SILS, semi-independent living services or supports for some populations. And is the difference between this, it's a consumer-managed budget, or, sorry, I'm CFSS and PCA and SILS are us kind of dancing in my acronym mind right now.
Mr. Chair and Representative Loeffler, this actually is the PCA program, and it is slated to change over to the new federal option, Community First Services and Supports, and so that's where the language and acronyms get mixed up. But because stricter dependency eligibility was put in 2009 that really cut off a lot of people with mental illness and other cognitive limitations who didn't need physical help. It's been a barrier for people who say need help because they're so depressed they can't get out of bed. They don't need the physical help, they need the emotional support and reminders. Same with medication. They can take it independently, but they need the reminders. Those reminders no longer qualify because it isn't constant. So this is an effort to really allow this very low-cost service to assist people, especially with mental illnesses, to stay at home and just get that supervision they need.
Thank you.
Representative Liebling.
Thank you, Mr. Chair. And I don't think we got a fiscal note yet.
No, we did. It's not prepared yet,
Another
Representative.
Okay. And Mr. Chair.
Representative Liebling.
Thank you. I had the amendment in with this bill, and I don't know if it's time to discuss that now, or if Representative Backer had something else first.
No, I mean, unless anybody have questions to this, we can talk about the A1 under the discretion of the chair.
If now's as good a time as any to bring up the A1 amendment, Representative Liebling moves the A1 amendment. Representative Liebling, to your amendment.
All right, well, thank you, Mr. Chair. So members, this is the same amendment that I brought last night. This is the, and I don't know if Representative Hamilton was here, so I'm glad you're here, Representative Hamilton. I just want to talk about this a little bit. So we heard a very important report from the OLA about home and community-based services. And we are spending almost $3 billion a year on home and community-based services. It's $2.8 billion in one place on the report, and it's a little different number in a different place. But regardless, we're spending an enormous amount of money trying to help people with disabilities and elderly through our home and community-based services, which are Medicaid programs, either through our state Medicaid or through our waiver programs. And the Office of the Legislative Auditor is telling us that we don't have good enough financial controls. And we took a vote on this last night, and almost all the Republican members voted no, which is really unfortunate, because this should not be a partisan issue. This is something the OLA is telling us we need financial accountability, we need more reporting, and the reason for that, obviously, is that we want to continue to provide these services. And in order to do that, we need to make sure that we know where the money is being spent. And DHS cannot really do that effectively without some further reporting that And the language in the amendment is language that DHS had put forward. I believe it's in the governor's budget as well, which did not actually get a hearing. So I just want to flag this for members. Last night, there were all kinds of excuses why we couldn't pass this and put it in the omnibus bill and continue to work on it, talk about it. And, I'm not going to put us through that exercise again, but I just really want to say to all of you members, the Republican members, I believe, have brought forward more than $2 billion worth of new spending in health and human services. And for those of you who consider yourselves fiscal conservatives or even just fiscally responsible legislators, which I hope we all are or strive to be unwilling to entertain putting into the omnibus bill a provision that the legislative auditor is telling us that we need to do some of this. I mean, it's eye-opening reading to read the report and to realize that we don't have good ways of really understanding where the money's going, because I know we all want the money to go to pay for the things that we want to buy. And they list in the report the 10 largest providers of these services, and the largest one is a for-profit corporation with whom we spend, I think it's about $140 million per year to one provider. Now, that may be very legitimate spending. It may be, and I know that these services can be very expensive, and the needs are very different from one individual to another and from one setting to another. But my goodness, we need to get our arms around this, folks. Anyway, I'm going to withdraw the amendment, Mr. Chair, and I hope that we'll consider this as we move along, because this has to happen.
All right, thank you, Representative Liebling. Representative Franzen.
Mr. Chair, if this amendment is adopted, would it have to go to civil law?
Representative Franzen, the amendment's been withdrawn, but it would have had to, yes.
Okay.
All right, Representative Backer.
Vote to remove one word, constant, thank you.
All right.
Or consider layover, something like that.
Representative Backer renews his motion, House File 1132 be held over for possible inclusion, and it is held over. Thank you, Representative Backer. Let's see. Representative Hamilton is up next. Representative Hamilton moves House File 1385 be held over for possible inclusion in the Health and Human Services Omnibus Bill. There is an A1 amendment to House File 1385.
Right, 1385. And that's our amendment, correct? Yes. Right.
Representative Hamilton moved the A1-1 amendment to House File 1385. Representative Hamilton to the amendment.
Thank you. This is clarifying, right? Yes. Clarified.
Mr. Chairman, members of the committee, this was a recommendation from DHS to clarify it and put the bill in the shape I'd like to present it.
Questions to the A1-1 amendment? Seeing no questions, all those in favor of adoption of the amendment, please say aye.
Aye.
Those opposed, no. The A1 is adopted. Representative Hamilton, 1385 as amended.
Thank you, Mr. Chairman, members of the committee. This would set a minimum payment of $140 for managed care and fee-for-service public health nurse and home visits, which would specifically target mothers and children. And with that, Mr. Chairman, I'd like to turn it over to our testifiers.
Welcome to the committee. Please introduce yourself for the record and proceed.
Right. Thank you, Mr. Chair and members of the committee. My name is Lorna Schmidt. I'm the director of the local Public Health Association. We represent more than 220 public health leaders from local public health departments across all 87 counties. We support House File 1385 and want that would increase the minimum MA reimbursement for all public health nurse family home visits. I would like to thank Representative Hamilton for his leadership on the issue. This bill also is supported by the Association of Minnesota Counties, the Minnesota Inter-County Association, and the Minnesota Coalition for Targeted Home Visiting. You've heard the benefits of family home visiting before, so I won't bother repeating them now. What I will say is that right now, all public health nurse family home visits are eligible for MA reimbursements. but the current rate falls far short of covering the actual cost of a visit, leaving counties to rely heavily on local tax levies to fill the gaps. Increasing the MA rate would help stabilize programs and build capacity to serve more families. To have the greatest impact, however, we need to be looking at both evidence-based programs and what are often called evidence-informed or traditional home visiting programs. In Minnesota, 39% of families receiving home visiting are served by an evidence-based model. The remaining 61% are served by an evidence-informed program. To be clear, we support evidence-based models, but we also recognize that they have limitations. Models are designed to serve families that meet specific criteria, such as being a first-time mom or enrolled by a certain age or stage of pregnancy. If you don't meet the criteria, you can't be enrolled in the model. Maintaining a valid model program also often requires certain staffing levels or annual fees that can be difficult for smaller and more rural counties to afford. Evidence-informed programs draw from the models and from best practices and are still led by trained public health nurses and professional staff. They are still subject to reporting to the state health department, and they offer local agencies more flexibility to serve high-risk families that aren't eligible for a model. In Minnesota, most, if not all, agencies that use a model also operate an evidence-informed program to reach as many families as possible. And nurses trained in a model may also serve families with an evidence-informed program. We ask this committee to support Minnesota's family home visiting programs and to support House File 1385, which would increase the MA rate for all public health nurse home visits. This would help stabilize programs statewide and ensure resources reach all counties and more families. In areas where evidence-based models can be expanded, it would provide additional resources to pursue that affiliated status. And for families whose circumstances may make them ineligible for a model, it would help ensure they can still access the supports that they need. With me today is Renee Froundines of Stearns County. I'm going to turn things over to her to share more examples from her.
Welcome to the committee.
Thank you. Mr. Chair, members of the committee, my name is Renee Froundines, and I'm the Public Health Division Director for Stearns County. Each year, Stearns County serves more than 220 high-risk families in both the Healthy Families America program and the Nurse Family Partnership program. And while we're really lucky to have both of these evidence-based programs to offer, we also have clients who do not meet the model criteria. This is not unique, and in some counties, many of whom are rural, these programs are not available at all. In those instances, public health relies on its foundation to provide what is called evidence-informed services or programs to support these families. And let me just give you an example to try to clarify this. So we may receive a referral from Child Protection where the family or the child was screened out. In other words, there was not enough evidence to warrant abuse or neglect interventions. But the family still wants services. If the child is too old, they would not meet the criteria for either Healthy Families America or the Nurse Family Partnership. In this instance, the nurse would use tools or interventions such as developmental screening tools or parenting curriculums, depression assessments, or home safety checks, all of which are based in evidence but are not really a program. All of these programs are prevention-focused and really work to reduce future costs to the child protection and to the corrections system. So besides helping us move towards stable funding for those services, this increase in the MA reimbursement would allow more counties to move to evidence-based programs, assure that staff are appropriately trained in instances that they would need that, increase the capacity to serve more clients, and further reduce the reliance on the tax levy, which has been filling any gaps in funding. I'd like to close with a quote that we received from one of our clients who graduated from the Healthy Families America program. She had lost 2 children to the child protection system because of her actions. But this is what she told us after completing the Healthy Families America program, and I'm quoting, "I cannot thank you enough for all you have done for me and my child. If I had known about this program with my other 2 children, my and their lives would have been different," unquote. I hope you'll support House File 1385 to increase the minimum medical assistant rate for all public health nurse home visits and help us continue to expand this important work. Thank you.
All right, thank you for your testimony. Further discussion? Representative Pinto.
Thank you, Mr. Chair. I'm a huge fan of home visiting in all the forms and really appreciate your work and Representative Hamilton bringing this forward. I just want to ask the reference to federal approvals. What is that? What's the timing on that?
That may be a question more, sorry, Mr. Chair and Representative, perhaps a question more for DHS. It's our understanding that DHS needs a directive from the legislature to apply for waiver, if that's the correct term, and so with support from the legislature, we would still need approval at the federal level to implement this rate.
And Mr. Chair, and how long does that take, whether that's DHS? I'm just wondering, so if we pass it in May, how long before we get that waiver?
Mr. Chair and Representative, I do not have the answer to that question.
Yeah, Mr. Chairman, I'd have to rely on DHS to answer that as well.
Okay, and I don't want to take more time, Mr. Chair. It makes me, and again, I'm very supportive of this, it makes me think a little bit about the amendment we were talking about before, because if the effective date is July 1st and the approval comes anytime after May 22nd, then at that point, we need to wait until the legislature's back in session in 2018 to then approve, and so that we'll be losing a good 6 months of support for this very worthy program. And again, this is just one example of many others. Thank you, Mr. Chair.
Thank you.
Representative Liebling.
Well, thanks. I just wanted to also comment that I think these are very important programs. Thank you for your good explanation of the evidence-based and evidence-informed issue that's, was a little confusing, I think, but that was a great explanation. And I just think that, in that results first program that we're doing now through MMB, I believe that they had shown that home visiting is one of the most cost-effective things that we can do. And I just want to really thank you, Representative Hamilton, for bringing this. I think that what we do for our really young kids is just so critical, so important, and it's so cost-effective. So thank you very much.
All right, further discussion? Seeing no further discussion, Representative Hamilton?
Thank you for the thoughtful discussion, and I ask for your support.
With that, Representative Hamilton renews his motion, House File 1385 be laid over for possible inclusion. 1385 is laid over. Representative Hamilton moves as amended. Representative Hamilton moves House File 1453 be laid over for possible inclusion in the Health and Human Services Omnibus Bill. Representative Hamilton to 1453.
Thank you. Thank you, Mr. Chairman and members of the committee. This provision would remove the disincentive for recipients to get married and requiring counties to inform caregivers about the income exclusion. And with that, Mr. Chairman, I will turn it over to my testifier to walk us through the bill and offer testimony.
Welcome to the committee. Please introduce yourself for the record and proceed.
Thank you, Mr. Chair. I'm Ann Krisnick, Executive Director of the Joint Religious Legislative Coalition, made up of the Minnesota Council of Churches, the Minnesota Catholic Conference, the Islamic Center of Minnesota, and the Jewish Community Relations Council. And this bill came about when talking with faith leaders across the state about families on the MFIP program, the Minnesota Family Investment Program, which provides cash assistance for primarily low-income wage earners. And one thing that we heard repeatedly was that there were people in their congregations that would like to get married but couldn't afford to get married. When I asked a little bit about that, they talked about the fact that adding an additional person's income would put them over the federal poverty guidelines. Often that would end up with their family having less money to meet their basic needs. So this bill really does two primary things. First, it doesn't create an incentive to get married or a reward for getting married, but it says if those families choose to get married for a period of 18 months, the new spouse's income would not be considered when looking at their continued eligibility under MFIP. And secondly, it makes sure that if their change in the law goes forward, that families will be informed of that. So our goal is to, if people would like to get married, we believe that marriage is a good, stable setting for children. It's good for families, it's good for children, both economically as well as emotionally and psychologically. And so this bill is to remove the disincentive that kind of unintentionally is currently contained in that. We also have an income cap included, so if the new spouse has an income that's above 275% of the federal poverty guideline, the income exclusion would not apply, and the 275 is the amount that's used for eligibility for pregnant women and children over 2 to be eligible in Medicaid. So that's where that amount comes from.
All right, discussion. All right. Any other testimony from the audience? Seeing none, final word, Representative Hamilton.
Thank you for the thoughtful discussion, and I ask for your support. We've heard that.
Representative Hamilton renews his motion that House File 1453 be held over for possible inclusion. 1453 is held over.
Mr. Chairman.
Last one is House File 1577, Representative Omar.
Chair Dean, presenting my first bill in your committee, so I
Oh.
snapped and I was told to start with the chair, so.
Wow, not necessary, but thank you.
Representative Omar, is this where I share the story on how we first met?
Not yet, let me present first. Give me a head start.
All right. Representative Omar, I will move House File 1577 be held over for possible inclusion in the Health and Human Services Omnibus Bill. 1577 is before us. Representative Omar, welcome to the Health and Human Services Finance Committee.
Thank you, Chairman, members. House File 1577, support for post-secondary students who are pregnant or parents. It's a really important bill to me. We are all acutely aware of the need for post-secondary education so that young people can get jobs that pay a living wage. The crisis in our childcare system, with childcare being neither affordable or available, crushing student loan debt, and the struggle of parents in balancing work and family caregiving responsibilities. All of these concerns joined together form an affordable challenge for post-secondary students who are parents of young children. Nationwide, 4.8 million college students are parents of dependent children, about 26% of all college undergraduates. The vast majority of these students are parents. 71% of them are women. About half of these students are parents who are single parents. Single-parent students are more likely than traditional students to be the first in their families to attend college, have low incomes, work full-time, and attend school part-time, need remedial housework, coursework, and experience domestic violence. Student parents also tend to have higher student debt more than other students and often live in poverty. During the 2011-2012 school year, nearly 43% of these student parents, around 2 million students, lived below the poverty guidelines. The challenges faced by student parents, especially single parents, result in their being much more likely than traditional students to drop out of college. The purpose of House File 1577 is to provide support for post-secondary students who are pregnant or who have young children so that they can succeed academically and graduate. The bill does two things. The two main sections, Section 1 requires post-secondary educational institutions to provide pregnant students and student parents of young children with fact sheets on their legal rights and a list of resources for support. And Section 2 provides grants for support programs for post-secondary low-income students who are either pregnant or parents of young children to help these students enroll, succeed academically, and graduate. Eligible grant recipients are public or private regionally accredited post-secondary educational institutions located in Minnesota and community-based organizations that have experience serving low-income pregnant women or low-income parents. The grants can be used for the following: to create a campus child care services, including starting or expanding campus child care facilities, child-friendly study rooms, student-parent support groups, or on-campus lactation rooms. The establishment or the continuation or expansion of student-parent programs that assist pregnant students or students who are parents of young children enrolled in post-secondary educational institutions. Child care assistance for low-income students. Scholarships for low-income parents. Financial assistance, including emergency assistance, up to $1,000 for housing, transportation, food, tuition, books, computers, internet service, child care, and other things. The grant program will be administered by the Minnesota Department of Health. The Department of Health has an existing program called the Minnesota Student Parent Support Initiative, which is funded by the Pregnant Assistance Fund of the U.S. Department of Health and Human Services. Since its inception in 2012, 9 colleges and universities have received grants from MDH for various student parent support programs, which is wonderful. But in its perspective, Minnesota has 30 state colleges and 7 state universities with 54 campuses. The University of Minnesota has 6 campuses. In addition, our state has dozens of private colleges and technical schools. This bill will allow the Department of Health to give grants to additional colleges, as there are some uncertainties about the continuation of the federal funding. That will allow this bill will allow MDH to continue its student parent support initiative if federal funding ceases or the focus of that funding changes. And with that, I have a testifier here to attest to how wonderful this program is and why we need to help support it.
Ms. Hurdle, if you'll introduce yourself and your affiliation and give your testimony to the committee.
Sure, thank you. My name is Jessica Hurdle. I'm 21 years old and I have 2 children. They're 2 and 4. I'm currently a full-time student at Dunwoody College of Technology. I'm pursuing a HVAC service degree and I'm finishing in May. I also work part-time as a HVAC service tech, so as you can see, my life is pretty full. Without all the support and help I received from Dunwoody, I wouldn't be sitting here in front of you today. I wouldn't be in this position. I wouldn't be starting my career at 21. I'm incredibly grateful for everything that Dunwoody has provided. I'm in a wonderful scholarship program there that, like I said, I wouldn't be here if it wasn't for that. So thank you for your time, and I definitely support this change.
Thank you, Ms. Hurdle. Any questions for the testifier? Representative Loeffler.
Well, thank you, Mr. Chair, and Representative Omar. I think this is a critical need, and it'll get a lot of families started out on the right step. I did see that you went to the office, to the Committee on Higher Ed Finance, and given the target that's just been revealed for this committee, I'm wondering if they also were equally enthused, and we might have some discussions about mutual efforts.
They were, and we definitely would love to explore that.
Thank you, Mr. Chair. I think we should look at partnerships if we need to.
All right. Any other questions for the testifier?
Mr. Chairman.
Representative Appleton.
Thank you, Mr. Chairman. As I stated, I'd like to just briefly share the first time that Representative Omar and I met. Mr. Chairman, if this was the starting line of getting a bill passed into law, and you see the checkered flag right here, checkered flag, right here, almost across the finish line is when now Representative Omar, but then not a representative, walked into my life and killed my bill. So I just want to say welcome to the committee, and do we have a roll call vote on this?
Yeah.
No, I'm just kidding.
I just also want to take this opportunity to thank you for co-authoring this bill.
What?
I really appreciate that. Thank you.
Representative Hamilton, if I remember correctly, I was a co-author on that bill.
Yeah, right?
There would be more treats coming.
And the committee would love to now hear how we're all authoring a new version of that bill together, right? This is what happens.
Anyone from the audience interested in testifying today? Seeing none, Representative Omar, closing comments.
Thank you. I just would love to have your support. This is critical. This is how I was able to get through college, and I really would love for you all to take it seriously and help our students.
Thank you very much. With that, House File 1577 will be laid over for possible inclusion. Members, that's the final bill on the agenda. Although Ms. Larson told me that with Holly out of the room and the chairman gone, I can start funding my own bills. And Representative Hamilton's. No, with that, we're adjourned, and Holly will keep you updated on our schedule as we roll out the omnibus.